Hello and welcome to New Planet School. In this video I'm going to talk about a heart surgery that fixes the aortic valve and the aortic root. In particular, it replaces the aortic root and the aortic valve. This is a surgery. It's very interesting, but also a surgery that I recently had. So if you're here to just listen to information about this type of surgery, that's great. If you're here because you might be having this surgery or you know somebody that's going to have this surgery, what I would recommend is get a piece of paper, something to write with so that you can take notes as you go along, because you're probably going to come up with lots of questions that I don't particularly answer, and you're going to want to get that kind of information. So if you want to do that, go get that now. Okay, if you need more information about this surgery, and you have maybe some anxiety about not knowing what's going to happen as you approach having such a surgery, just keep in mind that there are little booklets out there that they'll give you, and they'll describe all the things that you need to know. Your surgeon will talk to you, and these things are great resources. In this video, I'm not going to talk so much about what's in these books because I'm going to assume that you're going to get one. But I'm going to talk about a little bit more about my personal experience with it, although I will cover some of what's in here. It's best if you go get this book if you need it. Okay, so first of all, who am I? It's really important that you know who I am, because if you or someone you know is going to have this surgery, you might want to know whether or not my experience was like the experience that you're going to have. So let's consider the fact that I had this surgery on August 5th, 2013. So depending on when you're watching this video, this might be recent or it might be a long time ago. So you might want to consider that the technology and the methods and techniques might have changed during this time. I'm a 46-year-old male, and I spend most of my time sitting in front of a computer. By day, I'm a physicist, and so I do computing and that sort of thing. And at night, I do New Planet School. And now that the surgery's over and I've recovered, I can get back to making videos like this one. They considered me, when I was in the hospital, to be what they called extremely healthy. Now, if you know me, you might think I'm not the healthiest person around. Maybe I don't exercise every day or whatever. But what they think about in the hospital is I'm a person who never smoked. And that's a big deal because they might ask you to stop smoking before you have this surgery. It's pretty serious. If you have COPD, that could give you a very different experience because this is a cardiovascular issue. I didn't have diabetes, or my weight is pretty normal. I went into the hospital at about 175 pounds. And I don't do drugs or have any other illnesses. So from the perspective of having a surgery, I was considered to be extremely healthy. And if you don't have any of these characteristics, your experience could be quite different. Okay, so this will be a fairly long video because I wanted it to be fairly complete. And for that reason, I actually put together a table of contents so that you could jump around through the video, or you can come back and watch different parts again if you need to and find them. But here's basically the table of contents. I'll talk about why you might need such a surgery, and then I'll show some heart anatomy to sort of back up some of the ideas that are covered here. And then the bulk of the video will be this timeline where I walk you through all the way from detecting the problem all the way to several weeks after the surgery and everything else in between, including the big day of surgery. One of the things that I think gives people a lot of anxiety and thought, and people ask me lots of questions, is how much pain there is. So I have a special section just on the pain. So I'll go through all of these dates again, before, during, and after, and talk about how much pain there is and some of the ideas I came up with to actually make the pain less. And then I'll talk about some updates. What I did as I was in the recovery is I would jot down some notes, and I wrote them down and I put them in this video so that you can sort of see what I was thinking and feeling as I was going through the recovery. And then finally, I'll talk about how you can contact me if you want any further information, and a little bit about what you might think about when you have a surgery like this. Okay, so let's get started and talk about the need for this surgery. First of all, specifically, what is it? It's aortic valve and root replacement. That is a type of heart surgery in which two related problems are fixed at the same time. The aortic valve is replaced and the aortic root is replaced at the same time. And those are a valve and a artery that come off the top of your heart. They have to be removed and somehow repaired. Now, why would you have this? One reason you might have this is due to a condition called a bicuspid aortic valve. Bi means two, and cusp means it has two leaves. So it looks kind of like that, where you have one leaf and two leaves like that. It turns out that's the most common valve anomaly you can have, and it's the one that I had, so it's the one I know most about. It occurs in 1 to 2% of the population, so if you know 50 to 100 people, you probably know somebody whose aortic valve looks like that. It's twice as common in males, so lucky for me, and it's often seen with some other problems like aortic coarctation, which is a narrowing of the aorta. And there's a tendency for aneurysms to occur when you have this condition, which are obviously bad because you can that vessel can actually burst or leak, and so it's a fairly dangerous condition. There's other reasons. For example, the valve could be narrowed, what's called stenosis, which is caused by infection or calcification, and many other reasons. In most cases, whatever the problem is that's causing the valve and or the aortic root to be replaced, the surgery is often fairly similar. So what I'm going to say here would apply to most of those other cases. But sometimes there can be cases where that's not true. So for example, if just the valve is replaced, sometimes that can be done with what's called a minimally invasive surgery. And if you're lucky enough to have that, it's obviously minimally invasive. It's a lot better than the surgery that I had. And sometimes even just the aortic root is replaced, but in that case, I'm not aware at this time that there's a minimally invasive surgery for that. So that would be more like what I'm going to describe. So take these caveats into account as I go through this video. Okay, first of all, let's just start off with the main thing that you need to know. This is a serious surgery. If you've ever had a surgery before, this one might be a little bit more serious than some that you've had, and here's why. We've all probably had some anesthetic given to us at some point in our life for some procedure or something, but this one is particularly deep. It's deep enough that your lungs stop working, and certainly for me, I had never been given anesthetic to the point where I needed to be put on a respirator, and that is just how deep they want you to be before they go in and try to do what they're going to do. The other thing to keep in mind is that your sternum is cut in half. And so if you look over here at this picture over here, you can see the ribs, and then this piece of bone right here that's on the front of your chest, that is your sternum. And if you look at that red line right there, they're going to cut that down, and after they cut it down, they're going to take this part and move it over here, and this part, move it over here, and expose your heart that's right there. So you will have a pretty seriously broken bone when you're done that you're going to have to recover from. Another interesting aspect of this is that they stop your heart. They don't do this 100% of the time, but almost. They stop your heart because it's just an easier way for them to work on your heart. And so your heart is stopped and your lungs are stopped. And so you have to be put on a heart-lung type machine to keep your blood flowing through your brain and through your organs and so forth. So again, fairly serious. Your heart is open for some period of time, like maybe an hour or 2 hours, and to the open air. The inside of your heart is open to the open air. And the reason that's kind of important is that one of the most dangerous things about any procedure like this is infection. And that is something that they take great care to try to push down. And then there's many other issues that come up. You're going to have many IVs. That's kind of seems like it's minor. You'll probably be given a TEE, which is something I'll describe in a minute. That is often a procedure in and of itself, but you'll have that just along the way. You will almost certainly have a Swan-Ganz catheter. What that is a catheter that goes into your neck, into these veins, and into and around and through different parts of your heart. And that'll be embedded in your neck. Again, that can be a procedure in and of itself, but you just get that, again, along the way with everything else. You also have drainage tubes that will be coming out of your chest when you get out of the surgery, and on and on and on. And so it's a pretty serious surgery, so it's best to not go in thinking otherwise. Now let's look at what is actually going on here. Let's talk about a little bit of some anatomy. This is a top view of the heart, and what you can see is 4 valves. So the heart has 4 valves, you might remember, and it has 4 chambers. And what you can see here is the top part of the heart with 2 of the chambers removed. One of the chambers here on the left is the left ventricle, and over here is the right ventricle. And there would be a chamber on top of this valve, but it's been removed. That's one of the atria, and another chamber would be on top of this, but in this view it's not there. So here you can see 2 of the chambers and 4 of the valves. Now one of the things you see that's kind of interesting here is there's this valve over here called a mitral valve, and you can see it's a bicuspid. It has 1, 2 leaves. And over here you have a tricuspid valve, 1, 2, 3 leaves. And so we do have valves that have 3 leaves, and we do have valves that have 2 leaves. The problem is that sometimes you have 2 leaves where you should have 3 valves. So in this particular video, we're talking about the aorta, and this is the valve that we're talking about right here, and it should have 3 leaflets. And sometimes it has 2, like in my case, and apparently about 1 in 50 to 100 people. So this is the valve that we're talking about. It comes off the top of the heart, and it is a very, very important vessel, this artery, because it takes the blood to the rest of your body, as I'll show in a minute. One of the things you can see here that's interesting is the first thing that your heart does is it has this fresh blood that's got oxygen in it. It wants to send it out to the body, and the first thing it says is, I'm going to take some of that for myself. And so what it does is, the first thing it does is it takes that blood and sends it through your coronary arteries so that it can get blood for itself first. And so that's one of the issues, is that your coronary arteries are coming off of this valve, and the top of this, as it comes up, would be the root of the aorta. And so that's the whole part that has to be replaced. Okay, so here's a side view of what that looks like. And you can see now the 4 chambers, 1, 2, 3, 4 chambers, and then you can see 1, 2, 3, 4 valves. And in this case, the valve that we're concerned with is the aortic valve, which is this one right here. And what happens is, if this valve gets to be defective, you get several problems. One is regurgitation, where the blood flows backwards into the left ventricle, and that can cause problems. The left ventricle can expand, and this muscle can go to a size and thickness that it's not supposed to be at due to that regurgitation. And then you also have problems with that affecting the flow of the blood out into the body, and can affect locally what's going on right here, and that is the aortic root, is this part right above the valve. Okay, here's another view. You can see here, now you can see the coronary arteries very well. The heart pushes the blood out. First thing it does is it takes some for itself. What else would you do if you were a heart? And the valve's right in there, and then this is the aortic root. And then that blood, if it gets past there, fine, it goes up through the ascending aorta, through the arch, and down through the descending aorta, down to your organs down here. So you really do want this part operating pretty well. I mentioned earlier that often this problem is associated with an aortic coarctation. That's a narrowing of the aorta, and that actually usually happens over on this side, on the descending part of the aorta. Okay, so here are some pictures, close-up of what that looks like. Here is where the valve would be. Right here is where the valve would be, comes up, blood to the heart through the coronary arteries. This right here is the root, ascending aorta, the arch. Here's the carotids. That's the blood that goes up into your neck and then up to your brain. Very important. And then down to the rest of your body. Here's what it looks like in real life. Here's the valve down here. This whole thing right here is the root. The valve is inside of there, and this is a coronary artery, and this is a coronary artery. Usually you have two, and they're on opposite sides of the aortic root. And so this is the piece that needs to be replaced in this surgery. So here's a little bit from that little booklet I told you about, just to show you what's in it. It talks about stenosis, talks about the problems of the valve closing, which I mentioned earlier. It's called regurgitation. Blood tries to go up, but it can't, and it comes back down. And you can see the surgeon put this there for me. This is one of the problems that I was having. Leaky valve. Okay, so that's a little bit about heart anatomy. Let's go and look at what happens in terms of actually having this surgery, and we'll start the timeline with detecting this and go all the way through the weeks after surgery. So, detection. How do you detect such a problem? If you're lucky, like I was, the problem I had was congenital. It wasn't due to anything that I did. It was present from birth. And what's really nice about that is you get to watch it for your whole life and monitor it, and you can catch it at exactly the right time. And what that meant is, for me at least, is don't have this surgery until you absolutely need it. Use your heart as it's functioning until it's not functioning well enough, and then we'll go in and do something. It's not worth the risk of infection or having to have multiple surgeries. Wait as long as you can. And so that's kind of nice. So the second way you could detect this is shortness of breath. If your valve is failing, you have that regurgitation. You're not getting blood where you need it, and you can actually have shortness of breath. And this was something that I had as I approached the day of surgery and started learning about this more. I started noticing I was having shortness of breath probably for a long time. I didn't really realize it. I was making excuses. I'm getting older, I haven't exercised, whatever it was. But no, I was having legitimate shortness of breath as I was leading up to this surgery. You might also learn about it just through an exam, maybe through a stress test or an EKG, which I'll talk about a little bit later. Or you might actually learn about it because something goes wrong and you actually have some sort of pain and you have to go in and have something done right away. Hopefully that's not the case. That's sort of the worst case scenario, but it can happen. Okay, so you have it. Now you know you have it for one of those reasons. They're going to monitor it. So how do they monitor it? There's different types of monitoring. The monitoring phase can be short or last many years. As I mentioned, for me, it was my whole life in some sense, but really it was about 4 or 5 years where they were monitoring it very closely because it looked like things were changing. In fact, it looked like my aorta was getting bigger and bigger. I mean, in other words, it was dilating, it was getting wider. And we were watching that when in fact the valve actually started to fail, and that was ultimately the reason I had the surgery. During that time, once that passed, I started going in more frequently because they wanted to watch it more frequently and make sure that things weren't changing too fast. And then during that whole time, they're making lots of measurements and they're looking for trends. Like, for example, over time, you can imagine watching like the diameter of your aorta, and that's what they were doing for me during that period of time. But then in the end, my valve started having too much regurgitation, even though this was actually fairly stable. But they're monitoring all of these things. Okay, how do they monitor you? They make lots of different measurements, and the measurements start to change depending on how serious things are getting. So the one thing that they will do over and over and over is electrocardiograms, or EKGs, which are electrical signals of your heart, that's the cardio part, to make a graph. So electrocardiogram, electrical signals of your heart to make a graph that looks like that. And this is what they look like. And from these graphs, the doctors can figure out lots of things that your heart is doing based on electrical signals. For example, are these pulses coming at regular intervals? Sometimes you'll miss a pulse. What's going on? They can quickly look at this and get a sense of what your heart is doing. It's a pretty simple thing to do. They put little stickers on you the electrical pulses go through these wires and the nice graph comes out. And this is something they do pretty much all the time. When things get a little bit more complicated, you'll move up to what's called an echocardiogram, or just called an echo usually. It has a fancy name of Transthoracic Echocardiography, or TTE. I give you this fancy word because of what's going to be on the next slide. It's just an echocardiogram, or it's an ultrasound basically, but it has this fancy name. Transthoracic means they make a measurement through your thorax, which is just basically your chest. So this means through your chest. Echo means they use sound to look at your heart and make a graph. So make a graph of your heart using sound through your chest. That's what this fancy word means. So that's what it is. And you've probably seen these if you've ever had kids, or someone else you know has kids. You've seen these ultrasound sort of images that look kind of like this. And they can measure lots of details and look at the different chambers of your heart and so forth. They can actually even look at the flow with color. And this is kind of neat. This is kind of neat for me because I had regurgitation. You can actually look at the velocities of the flow in different colors. So maybe here the blues are things moving towards the detector and the reds are moving away from the detector, and you can see in great detail how the blood is flowing around. This is a great example. This is a VSD, or a ventricular septal defect. That's sometimes referred to as a hole in the heart, or hole between the chambers of the heart. And here you can see, sure enough, here's one chamber, here's another chamber, and there's clearly blood flowing between them, and you can see it through this velocity color. And so you can get a lot of detail with this sort of measurement, this echocardiogram. Now, when they get very serious, they seem to want to go to what's called a TEE. And a TEE has a different name. It's the same thing. It's a measurement of your heart using sound through your esophagus. So it's the same thing, but through your esophagus. So they basically put the measurement device right down here, which is very, very close to your heart. So they can get an excellent image of your heart like this, just like you do with a normal echocardiogram, but now it's close to your heart. One of the technicians I was talking to told me that he thought that this was about 10 times better than doing it through your chest. Sometimes if you have a lot of thickness there, or fat, or whatever, you can't get a very good measurement. But here, there's basically nothing in between you, and you get a really good measurement. Here's what one of those looks like. This is what it looks like. Goes down your throat, and you have this. And I had this done pre-surgery, just to make sure that they were making the right measurements, because they could get that more accurate number. And then during the surgery, I had it before the surgery so they could see the status of things. They made the change in the valve and the root, and then they did this again to make sure that everything was functioning properly. I have to say I'm glad they did that. Okay, so when they want a really accurate measurement, they will often go to cardiac magnetic resonance imaging, or MRI. And in this case, they're going to use a magnetic field. So you have this big magnet up here, and that magnet shakes all the nuclei in your body, shakes them around, and gets a nice image of all those nuclei in precise detail using the magnetic properties of the nuclei that make up the materials in your body. It's very accurate. While you're doing this, you typically have an IV connected to you, and you also, of course, have an EKG, because they want to look at the electrical signals and correlate those with what they see going on inside of you. This is very accurate. So as you get very close to having surgery, at least for me, I had 2 MRIs while I was working my way up, so they could get very, very precise measurements. And so here's an example of what a dynamic MRI looks like, and you can see the heart beating here, and you can see this image is a lot more accurate than the echocardiogram images that you've probably seen. And this gives them a lot of detail that they can work with, and they look at these right before the surgery. Okay, so now they've made all these measurements, they've used all these amazing tools, and now it's time to have the surgery, time to prepare and plan. So how does that go about? So here's just a list. The first thing that you're going to want to think about is when are you going to have this surgery. For me, being a 46-year-old physicist, it's not easy to just leave for a couple months, and so you have to really decide when you're going to have it. In my case, I was told I had to have it within a year. As I said, they want you to have this at the last minute because they want you to use your own heart as long as you can. But what that means is once they decide that it's time, and so you just got to go do that. As I mentioned, you're going to be out for some number of weeks. The younger you are, probably it's going to be a little bit less. The older you are, it could be a little bit more. Could be even up to 12 weeks, depending on if you are older and you smoked, or you're young and you're healthy. It's going to vary a lot. And the one thing that you have to keep in mind is you're not going to feel like doing anything. I thought, oh, well, I'm going to be home for 2 months. I can catch up on things. Definitely wasn't true. I didn't feel like doing anything. In part, it was uncomfortable. In part, you're recovering from trauma, so you're tired, and you're typically on drugs for the pain, and so you're drowsy. You're not thinking right. It's not so pleasant. You're not going to be able to lift anything over 5 to 10 pounds. If you do, you might regret it. You have a broken bone, your sternum, and if you lift something that's too heavy, you could shift those bones, and as painful as it is to say, they might have to go in and re-break that bone and start all over, and you definitely don't want to do that. And even if you don't do that, you're not going to have the full range of motion. So imagine having, between, say, 1 to 2 to 3 months where basically you can't do much. And if you're a person like me, 46-year-old physicist, that's difficult. I'm used to working every day and night and weekend and doing stuff. So that's definitely something you have to plan for. The other thing to keep in mind is you'll be making some very serious decisions. The most important decision that you'll have to make is obviously what kind of valve will you be getting. That's probably the most serious one, other than just planning your life and what it's going to be like for 1 to 2 to 3 months. What kind of valve are you going to get? If you're very lucky, you should be able to just have your existing valve repaired. That's the best case scenario because it's still your valve and it's still in place in your heart as it's always been. That's the best case scenario. Another option is to use one of your other valves, for example, in what's called the Ross procedure, where they take the pulmonary valve and put it where the aortic valve is, and then they fix the pulmonary valve with one of these other methods. That's one option. That could be an option for you. The other option is to get a new mechanical valve. And there are pluses and minuses to mechanical valves. That's an option. Another one is what's called a xenograft tissue valve. What does that mean? It's a valve. It's made out of tissue. It's not mechanical. And it is a xenograft. Xeno, of course, means foreign. So it means that it is a graft of a foreign tissue to make a valve for you. And that could come from a pig, a horse, or a cow. And that's nice because it's a real tissue valve instead of a mechanical valve. But again, it has pluses and minuses, and you have to make a decision what you would like to have. Another option is what's called a homograft. The only difference is the word homo, like man. And so this is a tissue graft that instead of coming from a pig, a horse, or a cow, comes from another human that so graciously donated their heart so that you could have an aortic valve and root that came from a human. This is what I had. I had a homograft tissue valve. And there are pluses and minuses to all of these, and depending on your age, your fitness, your lifestyle, completely changes the decision that you might make. And you might make a completely different decision than I did. So keep that in mind. Best thing to do is go learn all the pluses and minuses of all of these. And I'll talk a little bit about that in a minute. Okay, so here's from that little book that I mentioned. Again, you can repair the valve, put in a mechanical valve, or you can get a tissue valve. And so just to talk about some of the pluses and minuses, if you get a mechanical valve, it lasts for a very long time, decades, but you have to take a blood thinner for the rest of your life. And if you have a very active lifestyle, maybe you don't want to do that. It's up to you. If you have a tissue valve, the bad thing about that is they may wear out faster. But you only need Coumadin for a short amount of time. I was on blood thinner for 5 days in the hospital, and that was it. So these are some of the decisions you have to make, and you talk to your surgeon about it, and hopefully together you can come up with a good solution for yourself. The other thing that keep in mind is they may actually go in and fix some other things while they're in there. That's an interesting possibility. Like, for example, if you need to have a valve replaced and you happen to have a VSD at the same time, they might fix that while you're in there. So that's what I did. It had to do with my lifestyle and my age and so forth, and so that's what I ended up doing. The company where I got mine was this company called CryoLife. So of course I went and looked up CryoLife to see what's at their website, and sure enough, they have lots of information on these valves and roots. So here's the aortic valve and root, the ascending aorta, the arch, and then the vessels that go out to make the carotid arteries and so forth. And so this gives you some information about these human tissue valves and what can be good about them. They claim it's an excellent choice when you have a combined valve and aortic root problem, which is what I had. Again, common in patients with congenital bicuspid aortic valves. So for me, this sounded like a pretty good option for me. Again, go do the research and see what's best for you. All this information is out there, and you can discuss it with your doctor and surgeon. So one final warning, and I say that jokingly, is once you get to this point, be prepared to have a lot more friends. You don't know how many more new friends I got by doing this, because everywhere I go, I meet people who have had heart surgery, or they know somebody very close to them who has, and they all want to talk about it. So be prepared that as you do this, people are going to come out and that you might already know that have had this sort of thing, and they're going to want to talk about it. So you're going to hear some really good stories, and only you get to hear these stories because you are now going to be a unique person. It's such an amazing phenomenon that there actually is a name for it, amazingly. It's called the Zipper Club. And the Zipper Club is the club that you will automatically be in when you get out of surgery. And so if you are about to have this surgery, let me welcome you now to the Zipper Club. It's a club that has its own Facebook page, so if you're interested in going and seeing what the Zipper Club is up to, you can go to this Facebook page and you can get all kinds of t-shirts and mugs and whatever. This typically is what their logo looks like, is typically something with a heart with a zipper, and that basically represents that scar that you're going to have on the front of your chest, which represents the zipper over your heart. And so be prepared to have a lot of friends. And like I said, if you've had the surgery already, I'm now in the Zipper Club, and if you're about to have it, welcome. Okay, moving on the timeline, the pre-op appointment, getting very close to surgery time. The pre-op appointment occurs a few days before the actual surgery. Obviously for me, that was Friday, August 2nd. Surgery was early on Monday morning. One of the things that they gave me was this very special soap. This had to do with dealing with infection, so they start working on the infection problem the night before. You basically use this bottle of soap and just soak your body in it for a long time to kill most of the bacteria in your chest area the night before. They also will ask you lots of questions and make a lot of measurements. Of course, they do an EKG because they always do an EKG. They'll take x-rays, urine, blood. They'll take your vitals. They'll measure you for methicillin-resistant staph A. They'll ask questions about your health, as I mentioned, things about diabetes and smoking and these kinds of things. And of course, for me, nothing is ever simple. So for me, there was a little bit of a twist that during this time I was getting over a cold. And this actually stopped the whole interview process, and I was sent to meet with a PA to see if I would even have the surgery. It's a little bit unusual. You don't usually get a cold in early August, sort of almost midsummer, but I happened to have a cold, several days ahead of this, and the PA, had made a plan for the weekend, and turned out by Sunday I was getting over the cold, and so we went ahead and went forward with the surgery on Monday morning. And there we get to the day of surgery. So what's that like? Here I am on surgery day. Again, they come in, they clipped all the hair from my chest, so they just came in with a trimmer and just trimmed all the hair away. And once they did that, I got to take a shower with this soap. This is what that soap looks like. And basically soaped myself all over here to make sure there was no bacteria anywhere in sight. And so after a very long shower using a whole container of this, I was ready to get some very, very clean sanitary clothes and go into the pre-surgery waiting area. While I have this picture of me being trimmed here, the other thing I noticed after the surgery, so this picture was taken after the surgery, I also noticed that they trimmed the hair on my legs. And they didn't do this before the surgery, they did it during the surgery, and then they told me later what they had done. Sort of an interesting story. This was in case they needed to do a bypass, like they found some vessel, like the coronary artery where the tissue was a little bit messed up from the surgery. They would have to go into my legs, get some new vessels, and rebuild those coronary arteries. But as you can see, they didn't need to do it. But that's something that may happen. I mean, they clearly, for me, they prepared for it, but didn't need to do it. Okay, so moving on, I get to the pre-surgery waiting area. I feel a very mild prick just to numb my wrist area. If you look right here, there's a lot of missing hair. Right here, a lot of missing hair. I got a little prick there, but not bad. It was just a little, it was nice. But then they inserted a very large IV. And my wife was sitting there watching, and she was kind of freaking out about the size of this IV and what it looked like going into my arm. But because of the little prick I got, which numbed me, I didn't feel a thing. So I just sat there chatting away, sort of getting ready mentally to go in. They also measured my oxygen. This is a little device that you suck air out of. You try to hold this little blue thing between these two lines, and you get a reading, and they have a pre-surgery reading, and then after surgery you use this to try to get your breathing back up to where it was. Many people came through, talked to the surgeon, the anesthesiologist, the nurses that came through, and basically that was probably, I think it was probably about a half an hour, and then they wheeled me away into the operating room. I spent most of the time just chatting with the anesthesiologist, nice guy. We just chatted. He put some oxygen detectors to monitor the local oxygen here in my head. Kind of important when they're going to stop your heart. You'd like to know that you're getting oxygen in your head. So I was very happy that they were going to put those on my head. Then there was a person connecting things to the IV that they just put into me. They were going to give me anesthesia. I was talking to the anesthesiologist, and then bam, I was out. The last thing I remember was lying on the table. They were raising it up. I was staring at lights that looked like this, and then out. It's the last thing I remember. Then I came out of surgery, and this is me out of surgery, but not immediately after surgery, because one of the things you can see is I don't have the ventilator in here. I do have oxygen going into my nose through this nasal cannula, but I don't have the ventilator anymore. So they pulled that out. Then they put a mask on me, an oxygen mask. That's already gone, and now I'm just using a nasal cannula. So this is a little bit post-surgery in the sense that I don't have the ventilator in my going down my throat. I also have that Swan's GAN catheter, which I mentioned earlier. That is the catheter that goes into your neck and then down through your veins into the right side of your heart and snakes its way through the heart so that they can make very precise measurements. That was very interesting when they removed that. It feels like something you've never felt before. Okay, EKG, of course they do an EKG. They always are doing an EKG. So you have all these wires and stickers all over you. And in this case, I had a little monitor right here. So no matter where I went, they could monitor. The EKG would transmit to wherever they were from wherever I was. Of course, when this picture was taken, I wasn't about to go anywhere, but they were prepared for that with this EKG. You can also see that I have a pillow here. These pillows were made by volunteers of the hospital. And the reason it's sitting here on my chest is in case I cough. You probably can't imagine what it's like to cough after this surgery. But what you do is you hug this pillow, and it's supposed to help you be able to cough and sort of mitigate the pain to some degree. And it's shaped like a heart. And it's also used for getting in and out of cars, in and out of bed, in and out of chairs, or whatever you're doing. They give you this sort of pillow. If they don't give you this pillow, probably what they'll do is have you cross your arms so that you, basically it forces you to put your arms in a place where you won't use them for something that would pull on your chest. There's a lot of things you can't see here. There's 2 drainage tubes coming out of my chest. You probably don't want to see a picture of that. There are also 2, this was interesting, 2 electrical wires that went into my chest and up to my heart. That was in case they needed to, in some emergency situation, do some sort of defibrillation. I basically had my own personal wires to my heart. Again, what a strange feeling when they pulled those guys out. I doubt I'll ever feel anything like that. And then, of course, there's several IVs in both of my arms, and there's a urinary catheter because, as you can see here, I'm probably not in any position to get up and go to the restroom by myself. Okay, so that's what it looks like coming out of surgery. And this is what it looks like for a few days. Every day, a few of these things get disconnected. One day they'll come in and take the drainage tubes out, then they'll take the electrical wires out. One of the first things that came out was that Swan's GAN catheter in my neck. And then after a while, you start to get more recovered and start to look more like this. And so you can see here I am with my heart pillow, holding my heart pillow because after this picture is going to get taken, I'm about to get back in bed. This is probably the best I felt for those first few days. I have almost nothing connected to me, and I finally got to take a shower. It's probably one of the best showers I ever took. I just felt fantastic. You can see I have here, this is where my IV, I still had one IV. This is where another IV had been taken out. This is where the catheter had gone into my neck. But I'm nice and clean. I was wearing very tight socks and stockings, which are sitting right here to sort of keep things pushed up for, blood clot purposes. But basically, I feel, okay here, and I have this pillow to protect myself, so I'm not tempted to push on the arms of the chairs to stand up or to push on the bed to get back in. I just hug that pillow, and then I don't use my arms. But otherwise, looking pretty good. Of course, part of the reason I look so good here is that I'm under a lot of pain medication. The other thing that happens during this time is when you start taking your first shower, for about a month or so, you use antibacterial soap just to keep the bacteria off of your body. And so for the rest of my life, when I smell this soap, I will think of this surgery. And that's something I used for quite a while, even back when I was at home. Okay, so just to give you a before and after picture of what this looks like. Nice skin right here, and then this is what they did to me. And some of the things you can see here, this is actually, you can see the hairs growing back, so it's starting to be this is probably 2 weeks later when I was at home. There's this weird yellow bruise. I have no idea what that's about. There's obviously the main incision here. The bottom of the incision is kind of gross. Most of what you're seeing here, by the way, a lot of this stuff here that you see here is glue. And there's this glue strip that goes down here. Down here is a little bit gross. It's where the glue stops, and so you can have sort of a pussy sort of area there. Things can leak out and so forth. It's nice, you know, I'm a physicist, so it's nice that I now have these plus signs on my chest. It's always good to have those plus signs. This is where the tubes went into my chest to drain my chest for the first few days, and then those came out. And so that's sort of the before and after picture of what this looks like. And as you can see, I'm now an official member of the Zipper Club. Okay, so here's a little movie of me. I'm in a wheelchair, and I'm so excited. I get to go outside into the sun. I'm going home. And over here on the right, you can see there I am with my 2 kids. Over here is my sister, and my wife is going off to get the car and take me home. I have my pillow so that I'm not tempted to grab anything as I get in and out of the car. I got my really nice socks here, pushing liquids out of my lower legs. But that's about all I've got. Here I weigh, I think, about 185 pounds, which is the most I ever weighed in my life. And what's interesting about that is usually you think you have a surgery, you would lose weight. Here I actually gained 10 pounds. And the reason for that is they fill your body up with water to fill in all of the cavities and push everything out of the way, air bubbles, whatever it is. So you actually weigh a lot less. And so I went from 175 pounds going in. Here, in this picture, I'm about 185. And then now I'm about 165. It's been about 8 or 9 weeks since the surgery. And now I've actually lost weight. So that's going home. So now we get to the next time, the weeks after surgery. So wonderful to be home, because I was getting daily blood tests and getting, those are not that pleasant. I was getting nightly x-rays. They would do x-rays in my bed and put the x-ray detector under my back. I would get blood thinner injections in my side. They would weigh me every morning at 5:30 and wake me up to see how much I weighed. I had so many pricks in my fingers from checking my blood sugar. My fingers were bruised and just looked like little dots all over them from the pricks. Not to mention the usual vital signs and measuring my oxygen and listening to just generally people in the hospital. All of this went away when I went home and got to get into my own bed. Speaking of the bed, when you get home, you're going to want to decide, like, where are you going to sleep? Sleeping won't be the same experience that you remember, at least not for a while. Some people choose to use a reclining chair because you can adjust it more like what's in the hospital. You can buy things to put in your bed. You can pile extra pillows in your bed. You can do all of those different things. I chose to just use my bed as it was normally. And one of the things that I liked about that is I used that as an opportunity to lie down very flat so that I would stretch out the muscles and skin and everything on my chest so that they would stay stretched instead of getting a very bad posture, which can happen because you kind of hunch over to protect the muscles and skin on your chest. It's a little bit painful when I would lie down, but then it would go away and I'd have everything nice and stretched and my posture would be straight. And so that's what I prefer to do, but different people do different things. Okay, some things you want to be aware of that are going to happen at some point. You will sneeze. You'll have your first sneeze. You will remember it because you just won't be able to imagine just how much that first sneeze is going to hurt. So be prepared for that. Probably second to that is coughing. I started coughing immediately in the hospital. In fact, they want you to cough because you get a bunch of fluid out of your lungs. I had a partially collapsed lung, so they were really encouraging me to cough, which is about the last thing you want to do until you've sneezed, and then you realize it's the second last thing you want to do. Don't have people come in and tell you jokes. When you come home, don't jump on YouTube and look up your favorite comedian. That is not going to be something you're going to enjoy. So be prepared for these things that are coming. Okay, exercise. It's really important, obviously, that you get up and do lots of exercise. They'll put you on some sort of exercise program. Here I am, I think probably at 3 or 4 weeks post-surgery. I happen to have an elliptical machine in my house that looks out the window towards the mountains. Life is great. The one thing you can see is I'm putting my hands on these guys instead of these, because that would just hurt too much, because that would move my chest muscles. You can see here my chest is essentially not moving at all, and I'm sort of holding it in a very stationary position here to not move it. But this allowed me to monitor my progress, how fast I was going, my breathing rate. These actually allow me to measure my heart rate and so forth. And I prefer doing this than walking outside, because there's a nice view and I could keep track of my progress. During that time, I would check to make sure my oxygen level was getting up, and pretty soon, after about 3 or 4 weeks, I was actually higher than I was going in. I'm not sure if that means anything, but I was able to see when I was basically back to where I was, or even better. So important to do exercise. So that's the timeline, all the way from detecting the problem, monitoring the problem, to back on the exercise machine. And now I'm back at work and feeling great. Still have some pain, but it'll be a while before that goes away, which gets us to this this segment on how much pain is there during this whole process. So let's just go through that whole thing very quickly again and talk about how much pain you're going to have. The lead up to the surgery, nah, not much pain. You get EKGs, you get these echocardiograms, not a lot of pain, maybe some stickers or for the EKG that they put on you, not a big deal. When you get a TEE, if you do get a TEE, that's the transesophageal, that's when they go down your esophagus, you get an IV. IVs are never that pleasant, but not too bad. You know, when I had the TEE, I got a sore throat and a headache. Sore throat because they put something down my throat, and a headache from the anesthesia, which is a light anesthesia. Not too bad. After about a half a day, they were gone. If you get to the point where you're going to have an MRI, there's going to be a blood test before you go in to make sure your kidneys are functioning correctly, because they have to drain out the contrast that they use, and you're going to get an IV and have that IV for a while. When you have an MRI, my MRIs were about an hour and a half with an IV stuck in my arm, and having them have me stop breathing, breathe again, stop breathing, breathe again. And so it's not the most fun thing, especially if you're claustrophobic, but you know, basically in terms of pain, this isn't something really to worry about. Okay, pre-op appointment, again, not a big deal. Of course, an EKG, none of these really cause any pain. They give you a blood test, that's never fun. And then one of the weird things is they took these really long cotton swabs and stuck them way up my nose, which was just a weird feeling. I don't think I've had anything stuck up my nose that far before, but they wanted to make sure that I didn't have any methicillin-resistant bacteria, so that was fine. Not a big deal. Okay, day of surgery. Interestingly, it starts off with minimal pain. There's not so much pain. As I mentioned, they gave me a small prick in the arm before getting this giant IV, so I didn't even feel it. When you get into the operating room, they give you anesthesia, and it's a deep anesthesia, as I mentioned before, so there's basically almost no pain at all. When you wake up for many hours, you're still under the anesthesia. Why is that? The reason is that they could wake you up, and what I mean by that, they could give you a drug to really pop you out. But in my case at least, and as I understand it in most cases, for this operation they prefer not to do that because it is so deep and so traumatic to your body. They want you to just come out whenever you are ready and stay under anesthesia as long as you want. Of course, for me, nothing is simple. I popped out right away. It actually surprised them how quickly I woke up. But even when you do wake up, you're not really awake all that much, and you're not really totally aware of what's going on. So, quick story, when they took the respirator out of my lungs, once I was able to breathe on my own, they were talking to me, and I was communicating with them, you know, with my expressions and eyes and so forth, and they said, we want you to, on the count of 3, cooperate with us and cough this thing out as we pull it out. And my wife said I shook my head, I cooperated, and when they counted to 3, I went through the right motion, and they got this thing out of my lungs. I don't remember any of it, but my wife says it looked like I was completely aware of what was going on. It's as if it never happened. I don't remember it. And part of that is the anesthesia, but also the pain meds are pretty strong during the first few days, obviously. And so for the most part, you're not remembering things. The pain is pretty low. But then comes the latter part of the first day, and you kind of start to wake up a little bit. The anesthesia is wearing off. You're staying awake longer, and then it'll hit you. You will have pain probably unlike anything you have ever felt before. It's pretty severe. And that'll hit, for me, it hit on the end of the first day. And it was pretty frightening. They asked me, could you please tell us how bad your pain is on a scale from 0 to 10? And my answer was 13. I mean, it was really off the scale. I mean, 10? Well, that's easy. It was pretty bad. So continuing into the next few days, for me, the next few days was the worst. The second and third days was just sort of mind-boggling amount of pain. The nurses seemed to concur with this, saying that these tended to be the hardest days when they talk to people. The anesthesia is mostly gone, and the pain meds can only do so much during those first few days. As one nurse told me, unless we have you under anesthesia, we can only get the pain down so far. And so you are just going to be in some amount of pain during that time. So basically the end of the first day, second day, and third day aren't going to be fun. The best thing to do is manage that pain the best you can and just get through it. You'll be fine. Some of the events that make the pain a little bit worse is when they decide to make you sit and when they make you walk. For me, those seem like absolutely crazy things to do given the amount of pain that I was in, but you just do it. And it's for your health. It's just really bad for you to be lying on your back. You need to get up and move around and just do it. There's also some unpleasant things that will happen in addition to the usual sort of pain you have from the surgery. They'll remove the chest tubes. That doesn't feel very good. Other things might not feel very good. And the one thing to keep in mind is that there'll be times when there'll be breakthrough pain. And what I mean by breakthrough pain, if you're not familiar with that term, is that you'll be on some sort of medication. So for me, I was typically on 2 Percocets. And that was typically pretty good. After a while, I went to 1 Percocet and 1 Tylenol, and I would sort of go down from there. But they can't give you more than that, and sometimes the pain is just way, way more. It feels like you're not on any Percocets. And so during those first couple days, you just have to learn to get through some of this. Okay, so now about a week later, towards the end of your hospital stay, at least I was in there for just under a week, the pain meds start to keep the pain to reasonable levels. As you saw in some of those pictures, I was, half smiling and sort of doing okay. But one of the tips that I would give you is it's really important to learn what the rules are for the pain meds. And in some cases, these were not explained to me in great detail. And I'll talk a little bit in a bit about how you can learn to manage that a little bit better. But for example, I was not told that I had to tell them when I wanted a Percocet. And I can have a Percocet every 4 hours, but it was required that I actually verbally say something. They wouldn't give me one unless I said something. And in hindsight, I sort of understand what's going on, but during the time, I didn't know this. And so I would be waiting and waiting for my pain medication, and it would never come. And that's, as I will show you shortly, put you in a kind of a bad situation. Hopefully you won't have that problem. There's, of course, a lot of low-level irritations, as I said, blood thinner injection, finger pricks, getting out of bed, and so forth. It's definitely not a lot of fun in the second half of the first week, but nothing like the first half of the first week. That first, second, and third, and part of the fourth day, not very, very pleasant. But after that, you're sort of starting to get used to it, and the pain meds are starting to catch up with where you are. Okay, so for the next few weeks, what is it like? for the next few weeks, they send you home. You're going to have good days and you're going to have bad days. And as they said, the bad days will always follow the good days. When you have a good day, you're going to overdo it. And then the next day, you're going to feel bad and you're going to rest. And once you're rested, you're going to have a good day and you're going to kind of alternate. That's what they told me. And that's kind of what happened to me. I would push it and then kind of suffer a little bit the next day. Not too bad. My pain was pretty much tied to when I took my pain meds. If I took my pain meds on a nice schedule, I was fine. If I somehow deviated from that, I would have pain. And so it was pretty simple. The pain meds that I had were able to control the pain, but I had to make sure I didn't miss something. And I'll talk a little bit about that in a bit, about how you can learn to control that a lot better, something I learned during this whole process. The other thing that was sort of interesting is I generated my own new forms of pains, because nothing's simple for me. And so one of the things I found is by holding my chest in safe and comfortable positions to sort of protect things and keep things from stretching too much, I actually made my back muscles hurt really badly because I was using them in ways I never did before. So be careful that you don't actually generate as much pain from being stiff as you do from the surgery itself. Okay, so here's some tips I learned about controlling the pain that were pretty interesting. At least they work for me, and hopefully they'll be able to work for you. So one thing to keep in mind is that I was given Percocet, as I said, but they allow you to switch to something else if you need to. I didn't need to. I didn't need to switch, but keep that in mind that, ahead of time, maybe Vicodin is better than you, and you can ask for that. Maybe they'll let you, maybe they won't. But for me, they gave me the options of different things that had different side effects. One of the famous things that Percocet has a side effect, for example, is constipation. And if that's a big problem for you, you might not want to be on that. So keep that in mind. One of the main things was there was a rule, as I mentioned, that I didn't really understand in the beginning. And so make sure that you or whoever you're with pays attention to this. And what it was for me is I could not have more than some number of pain pills, which was for me 2 Percocets, in a 4-hour period. And they would not give them to me unless I asked. Okay, and this is as I said, it's very important. For example, suppose you fall asleep for 6 hours. You're going to wake up in a lot of pain because you're used to having that Percocet every 4 hours. And I'll show you some graphs in a minute for how that works. So if you're planning on sleeping for a long period of time, and they let you sleep for a long period of time, or you're at home and you're going to sleep for a long period of time, you're going to wake up in a lot more pain, and it's going to take you a while to catch up, and I'll show that in a minute. For the first few days right after surgery, as I mentioned, you're going to have this type of breakthrough pain that just breaks through your pain medication. And you're going to need to have a special medication for that because, like for me, the Percocet was, it's as if it wasn't even there. For me, the drug that I had was called fentanyl, and that is supposedly about 100 times stronger than morphine, which is quite a bit. And that was something that I had to know that I could ask for it and when I could get it. And it was crucial to have that because when this pain came, you needed it. And what was nice about it, they pop it in your IV, they start to push it, you immediately start to feel much, much better. But it only lasts for about 20 minutes. And so keep that in mind. It will get rid of your pain and you'll feel pretty good instantly, but it doesn't last that long. So learn how to manage given that. Okay, so let me just talk about something called pharmacokinetics. Pharma is obviously drugs. Kinetics is how things sort of happen and move around. And let's look about how that affects drug levels in your body, just to give you a graphical picture of why it's good to manage your drugs better than they might actually suggest to you. So let's look at this curve right here. Let's imagine that over here I'm plotting the drug that's in your system, and this is the time in hours since you took your pills. And the way they describe it in the hospital, it's as if it's on for 4 hours and then it's off, and then you take another one and it's on for 4 hours and then it's off, and it's on for 4 hours and then it's off. That's how they'll talk to you about it, but it doesn't look like that at all. This is typically what it will look like First, you'll take your pain medications, it'll get absorbed into your blood, and it's not doing anything for a while, and eventually it'll go up to some peak, and then at some point your body will start to drain it out, and it'll drain out of your body for it takes a long time for drugs to get out of your body. So you get a shape that looks very different. This is actually what it looks like. So what happens if you take pills every 4 hours? This is what it'll look at, the drug in your system, it will look like. It'll come up from 0. This is the first pill. You get to 4 hours. They let you take another drug. For me, it was Percocet. I take another one. But because the first one hadn't drained out, this one actually goes higher. And then after 4 more hours, I take another set. It will go even higher, and then higher and higher. And you can see it's leveling out to some sort of average value. So what will happen is, essentially, your pain will vary between this low point, right when you take your drugs, up to this high point up here. And this is basically the range of your pain that you'll be in. But notice that that value is a lot higher than what happens when you take the first one. So imagine if you miss a pill. So you're over here, you take your first one, it goes up, you take the second one, and then you fall asleep. And you don't take one because you're not there to ask for it. Then you take another pill, it pops up. Now notice where it goes up to. This is when you feel at your best. It's lower than this, and it's definitely lower than the high point over here. So what you're doing right here is you're trying to catch up, and that'll take you 4, 8, 12, 16 hours before you can actually catch back up to this peak value like this. So this is typically how pharmacokinetics work, how drugs work in your system. This is what it looks like for Percocet. Now, as you probably know, Percocet is 2 drugs. It's acetaminophen or Tylenol and oxycodone. And so I looked up some of the graphs for you, and this is what the concentration in your body does versus ours for oxycodone. And so suppose you have a 5 milligram, it does this. It starts very low, goes up, and then it drains out after about 15 hours. So it looks a lot like this. And so this is indicative of what it's like to take oxycodone. So having these pictures in your mind and keeping in mind what the rules are that they have can make you get through your the pain control with your drugs a lot better. Okay, some side effects, just so you know, so you be prepared for these. You might have trouble sleeping. That's often from the drugs. As I said, constipation, really bad from the Percocet. I think everybody wanted to talk to me about constipation for my final days in the hospital. That's just a big deal. Do you want to talk about anything else? They wanted to talk about constipation. Muscle aches. I had bad muscle aches, as I said, because of the way I was trying to control my body. I had lots of itching and numbness. I had a severe loss of appetite. That's how I went from 185 to 165 pounds. It took me about 4, 5, 6 weeks, and I'm still at 165 pounds and not eating as much. Sleepiness, often got sleepy. You might say, is this a contradiction? And it's not. Sometimes I would just fall asleep in the middle of the day, and then I would be up all night. Kind of crazy. The drugs, I think it was the Percocet, would cause me to have profuse sweating. I would wake up soaking wet in the morning. That's another thing. Possibility of infection. I think nothing simple for me. I think I got a bacterial infection or something in my left armpit, I think from the sweating. Kind of strange. But once I started using all that antibacterial soap, it was immediately gone. Not a big deal, but lots of different things can happen in addition to the fact that you've just got a very deep cut and a broken bone. You get lots of other stuff to come along with it. Okay, so let me go through my updates just so you can see sort of how recovery actually goes. I won't go through these in detail because you can pause the video and actually read it yourself. But this is after the 3rd week, and there's the date. And you can see I woke up today feeling pretty good in terms of mental clarity. That's basically because of the drugs. Took a Percocet at 7:30 a.m., although it wasn't clear after a few minutes that I needed it. I guess I took the Percocet and I thought, actually, I feel pretty good once I got up and I was walking around. Hadn't taken a Percocet since 10:30 the night before. did some internet, which is basically what I did all the time. I read the news, checked my email, that kind of stuff. And I did 17 minutes on the elliptical machine. And so you can see I'm feeling pretty good. I'm doing the internet, and I'm exercising on the elliptical machine. This is in the 3rd week. Took a shower. Showers tended to be fairly painful because you're moving around a lot. You're soaping your hair and you're getting dressed. In the end, I was glad I took the Percocet. Showering for me was like the most motion of my upper body that I needed to do. And so showers felt good, but not afterwards. I needed a nap. I often fall asleep in the afternoon. And then the rest of the day, I only use a Tylenol. So that's pretty good. 1 Percocet, some pain, and then I use Tylenol. So not bad after the 3rd week. 4th week, I did a little experiment with myself to see where I was with the Percocet, because I really wanted to get off the Percocet. Everybody is very worried about addiction. So I only took 2 Percocets in the entire day, and I was noticeably uncomfortable. This is something that you may or may not want to do. I kept experimenting with myself to see, when can I get off this Percocet? When can I get off the Tylenol? And I would back off, see what the pain was, and I would get a little bit more on the drugs to compensate. I guess I like to experiment. Maybe you don't want to do that, but I wanted to just see where I was. But by the 4th week, I'm going out and having Indian lunch buffet after the 4th week already. It's fantastic. And mainly, most important thing is I started working on this video. And so I actually started doing something after the 4th week. It's not all bad. A few days later, I actually met with my cardiologist, and they did the measurements, and particularly the echocardiogram, and I got maybe some of the best news I've ever gotten in my life. Everything looks perfect. The valve looked perfect. The left ventricle had shrunk back to its normal size. Some of the best news I've ever gotten. She wanted me to get off of the Percocet. And be totally off of it in 2 weeks after this. Remember, it was August 5th, and this is September 4th. So about a month later, she's like, okay, that's enough. Get off of the Percocet. So what I did is I immediately quit. I never took another Percocet after that conversation. And part of the reason is I think a lot of the pain I was having was from back pain and not the surgery. So I thought, I'm just going to deal with this, and I haven't taken a Percocet since. So after the first month, I was trickling down on Percocet, and then I just stopped. Okay, here's another thing that happened to me. I'll just throw this in before I finish, because nothing simple for me. During my recovery, I had 2 unusual feelings in my left arm. And one was an occasional numbness. And then the strangest thing, I felt like I had a string of pearls under my skin that felt like this. If you felt my skin, it's like somebody put a string of pearls and then put my skin over it, and I could feel these little bumps. So I mentioned this to my wife, and she did some online research and realized that this could be what's called thrombosis. And thrombosis is not in and of itself particularly bad, but there is something called deep vein thrombosis, which is potentially deadly. And you need to have measurements made to make sure that you don't have deep vein thrombosis and you just have normal thrombosis. So guess what? I was back in the hospital. I had ultrasound measurements of all the veins in and around my neck, down into my heart, down through my shoulder, and all the way down my left arm, all the way to my hand. And it's kind of actually pretty interesting to see that. But luckily, I didn't have deep vein thrombosis, but what's called superficial. And what that means is that the little pearls I could feel were on the surface close to my skin, and they didn't go down into my arm and towards my heart. If they did, what can happen is those bumps that you feel, these are actually blood clots. So if you've ever wanted to feel a blood clot, I can tell you what it feels like. Those blood clots can break away. They can go into your heart. They would go in, because it's a vein, it goes into the right part of your heart, the right chamber, the pulmonary side, which then goes directly to your lungs to get new oxygen. This is the blood coming back from my hand. And that can cause a pulmonary embolism, and among other things, can kill you instantly. So what I did is I put hot towels on my arm at night and see if it'll fix itself. I don't know yet. It's possible that I could lose that vein forever. Luckily, the body is redundant and it's not going to cause a problem, but we'll see how that goes. Just another interesting thing that happened along the way. So in this movie over to the right, you can see the actual vein because it has a bruise on it, and I think if you look very closely, you can actually see bumps, and each of those bumps, is an actual blood clot. And so I don't know if you can actually see it in this video, but that is the vein, and you can actually see, I think, the blood clots, those things that feel like little bumps. Okay, so almost done. Please contact me if you want any more information. Here's what I prefer you do. If you want to contact me, use the comments below this video because it gives the opportunity for everybody to see your question and to see my answer. So if you have any questions about this, I can't answer everything. I had one experience. I can tell you whatever I know. But it would be great if everybody in the community could learn about this through your comments. If for some reason you don't want to have it public, feel free to contact me at the New Planet School email address. Okay, now one final thing before we end is when you have a surgery like this, especially when you have somebody else's heart now in you and attached to your heart, you feel like you're glad that somebody was able to donate that heart. And so it got me thinking about this of, just how many lives can one person save? Like this person, I don't know who it is, who donated their heart, and I have it. How many lives can you actually save? Because we often think about how great it is if you can save someone's life. So how many lives can you actually save? So I actually went and looked it up while I was in my recovery, and it turns out that the number of lives you can save is 8. Very easily. It's easily possible for you to save 8 lives. And how is that? Turns out there's a website run by the United States government on donating organs. And I found some very interesting statistics there. This is the sort of thing you think about when you're recovering. About 120,000 people are waiting for an organ. And this is really sad. 18 people die every day because they're waiting for an organ because there simply aren't enough donors. And here's the really amazing part here is if you are a donor, you can save up to 8 lives. And the reason for that is your body has many organs in it and all of them can be used, and you can save actually up to 8 different lives. So something to consider, when you have a surgery like me and you have a homograph from someone else that donated an organ, it makes you realize just how important it is for there to be organ donors out there. So you consider it. I mean, I am definitely an organ donor and encourage everybody to do that. Okay, and with that, that's the end of this video. Thank you for being here and hope to see you back here soon.